presentation. Now we invite Dr. Arup Chakrabarti to talk about cataract surgery in ACG.
Okay. So, a very good afternoon, friends, and thank you, the chairpersons. Thanks, AIS, for the opportunity. See, lens extraction, whether it is cataractus or not, in the presence of angle closure glaucoma, have always been a challenge. You know, I mean, I think there is a greater challenge lying in how to deal with the clear lens in the presence of angle closure glaucoma, and that has generated, legal standard generated a lot of discussions. I'm not going into that. I'm talking today about a situation where you have a patient with a visually significant cataract and angle closure glaucoma on multiple medications. So, nothing financial in what I'm going to talk about. So basically, these patients require an additional, a more concerted workup. First, we need to take a call on what type of cataract surgery you're going to perform. At what time would you like to perform the surgery, particularly if the patient is just after an acute episode. Preoperative workup and preparations differ significantly from routine cases. IL-PAR formula also play an important role, particularly if you're dealing with short axial length eyes. Counseling is of paramount importance, and it will become clear as I go on with my presentation. There are intraoperative challenges and issues which are additionally faced here. For example, there will be visibility issues. Cornea may not be very clear, and of course, many of these patients may have a very advanced cataract. Cornea is unhealthy because of previous episodes, acute angular episodes in the past. Pupil again, will be irregular. There may be posterior synechia. AC is usually more often than not is shallow in these situations. Many of these patients have compromised zonular status. Usually they have a hard nucleus, and then at the end of the cataract surgery, what sort of intraocular lens are going to place? And then post-op IOP management also becomes more intense here, because there are a lot of IOP fluctuation. You need to follow how the IOP has been impacted by the cataract surgery. So all this require a long-term follow-up. Now, I have done a lot of such cases in the last maybe 10 years, where before I embarked on this kind of management, I used to perform a combined surgery, trabeculectomy and cataract surgery together. But then I realized that many of these patients, their logistic issues, patients are very thin, very fragile, very difficult to perform trabeculectomy and the post-operative follow-up. They're coming from a long distance, they can't come frequently. So I thought I'll just do only cataract surgery, careful cataract surgery, and I'm going to present one of those cases here. It's an happening case, so otherwise also it will be quite an interesting video. So this lady actually had intumescent. She was operated. She had her glaucoma was managed elsewhere a couple of years back. You can see EAC, PI, both eyes. So she presented to me with an intumescent cataract, and after the first eye was done, second eye, and the complications were exactly similar. So let me show you. Now, I had used IV mannitol, a good digital massage. Such patients are always under peribulbar block, and AC was shallow. It was an intumescent cataract. Pressure was in the mid-teens, with all this manipulation. She was on 2 anti-glaucoma medications already. So here the surgical challenge. So ideally, you would have tried to perform a combined surgery for this case. trap plus phaco. So here, I just decided to cataract surgery. This itself is going to be a challenge. So we always do a two-step phacoemulsification in these situations. So this first stage is very crucial, because if it runs out to the periphery, then your whole surgical pathway is going to be altered. So it started out with a cystitome. Most of the time it works out, but then I didn't have much purchase on the capsular flap, so I switched over to the ureter forceps. Please remember that whenever you want to form the anterior chamber in these cases, always better to dump the OVD, a dispersive OVD, not in the periphery, not in the center, because if you brew it in the center, the viscosity of the OVD, it takes the flap peripherally, so you lose the battle. So very carefully it was performed, and there was a small pedicle connecting the anterior capsule to the capsular flap to the anterior capsule, so that had to be very carefully removed. Now capsular bag decompression has to be done. Before that, since we had to use the cohesive OVD, we had to evacuate the anterior chamber, otherwise there will be no pressure gradient which will bring the lens matter from the capsular bag out of the anterior chamber. So here, for some reason, the decompression process was not working out as per plan. I used irrigation to start with, then milking technology massaged the anterior capsule from the peripheral area all around, and to bring the flaky lens matter into the center. So idea is to decompress not only the anterior aspect of the capsular bag, but all around, even behind the nucleus. That has to be done. So I thought that I had achieved a good amount of capsular bag decompression at various levels. Then went ahead with my two-stage rexis. Prior to that, of course, you make a nick with my intraocular micro scissors. So the decompression was done for quite some time. Now, the anterior capsule was again stained with trypan blue dye. So at the first incision itself, if you see when I gave the relaxing cut here, it ran to the periphery. So there was nothing that could be done to retrieve it. So I decided that I continue with phacoemulsification, though here the option was to do an manual SICS technique. I'm quite competent in doing it for the last 30 years. So here, before I enlarge the capsular opening, see, whenever there's rexis tear running to the periphery, it is important that you don't build up a lot of fluidics, high pressure situation in the capsular bag. So that will definitely end up with a wraparound tear. It will go to the zonules, to the capsular fornix, and go behind. So the lens matter bag was decompressed further by bimanual irrigation aspiration. So I would require a little greater, as I've just mentioned, a larger axis, bigger axis to manipulate the lens matter. Because if it is a small, again, when you perform phacoemulsification, the fluidics, the turbulence, etc., that build up, that again is detrimental to the rexis tear that has happened. So the downside of this strategy is you have too big a capsular opening, and there's one runaway to the periphery, and maybe I'll just finish up in a minute or so. And so the lens matter tends to levitate to the anterior chamber. So you need to always use a good quality dispersive OVD, frequently top of the anterior chamber, and perform phacoemulsification. So as you perform phaco here, I will be starting off with a very high power, higher than what I would have done normally, because I don't want any translation and movement for the nucleus. You don't have to perform a cortical cleaving hydrodissection. The nucleus rotates pretty well. So a phaco chop was done, and at the end of the, so this is important. Now my rexis tear has happened superiorly. So I changed my plan from a single piece lens to a 3-piece hydrophobic acrylic lens. Is a sensor lens. So when the leading haptic comes out, the way the hand moves, invariably there is some amount of manipulations that happen superiorly, and here is where the rexis tear is happening. So I have to ensure that the leading haptic goes in front of the capsule. Otherwise, there will be more stress to the capsular bag and chances for enlargement. So leading haptic was now, I thought I had kept it in front of the capsule. But so much of manipulations involved in pronation and supination of your joints. So at one point, I was not really sure where the leading haptic landed up. So injected some more OVD, and then I brought it up with the Sensky hook from the side port into the anterior chamber. The trailing haptic was generally kept by a compression technique. I try not to dial these cases. So you can ensure that the haptics are placed in the sulcus, and that the optic is captured posteriorly. So the optic is locked in place. This is the day one picture, a clear corneal incision suture was used, and this is more than the usual SKs that I see in my cases. But anyway, it was a tough case, and first post-op week patient did pretty well. So basically, I would sum up by presenting a few pearls which I've learned over several decades while managing the cases. You should have a definite pre-op strategy and decision tree in your mind, plan A, B, C, so on and so forth. IV mannitol I was not using routinely, but today, earlier I was using it only when the antechamber was less than 1.5 millimeter in depth. Today I use it routinely for all annual closure glaucoma. Perivalvular anesthesia no longer do topical. Intermittent globe compression as advised by Osher, but I use a digital massage. Adequate size rexis. Cortical cleaving dissection is important, not in this case, but when it is a nuclear cataract, most of this case is a hard cataract, so it is important that you don't have a pupillary snap, so it has to be done carefully. Rexis size also have to be adequately titrated. And I have had cases where the pressure has suddenly gone up intraoperatively. Advanced cataract, I was not sure it's supracortical hemorrhage, but if you have the slightest suspicion that dealing with supracortical hemorrhage, abandon the surgery, close the incision, bring the patient back, do an ultrasound, and wait for a couple of weeks for the blood to get absorbed. Thorough capsular polishing is very important because they have a lot of capsular fibrosis post-operatively. IOL type, again, is single piece hydrophobic acrylic lens. Role of passband vitrectomy when the intraocular pressure is very high is there. I've done a couple of cases like that. Post-op IOP control is very, very important. Now, this was actually an article which was, I think, published by IGO group, LB Prasad group and IGO, which sort of corroborated whatever my clinical experience had been. That wherever TRAB was also included, they had performed cataract surgery with significant and sustained intraocular pressure control. So phaco alone can be considered as the initial procedure, even in advanced or medical uncontrolled primary angle closure disease eyes. Having cataract before glaucoma, before glaucoma filter surgery, a common procedure. So that is it, friends. So I mean, you can definitely think about just a cataract surgery in many of these tough situations with coexisting angle closure glaucoma. Thank you very much for your attention. Sorry for the extra time that I took, because I heard the previous speaker say that we don't have a full house, full quorum. So I took the liberty. Thank you.
Can I have one question from you? Arup, if some patient is having age of say around 45 or 50 and he is prone for acute angle glaucoma but no lenticular changes, would you prefer iridectomy or will you advise her for phaco and IOL implantation if the patient agrees on your advice?
So it is again a controversial decision, but since you asked my opinion, I would not do a clear lens extraction. Even if it is a patient where, like let's say fellow eye of an eye which has undergone an attack, I just do a PI, observe the patient, and in case the patient has an episode, then I would do a clear lens extraction. But no, but I mean, I know some of my friends who may have a different view, but this is what I do for my practice.
Thank you.
How do we know that we have done enough decompression, when you did the first small rexis?
Yeah.
And you did a lot of decompression. Then even after all that, when you cut it again, it's extended. So is there any way to know that?
No, I think it's a very valid question. In fact, the first eye also had the same problem that both eyes had symmetrical complication. So I feel that if my primary rexis had been a little larger, it was 2 millimeter, it was quite irregular. The problems of making a larger rexis is, it may run to the periphery. Here it was a very shallow anterior chamber. I had given IV mannitol, so some amount of dehydration of the lens had taken place, vitreous had taken place. In spite of that, the space was a major issue, constraint there. So if you have a small rexis, the two things happen. One is when you try to flush out the lens matter, if you just stretch the capsular rexis margin, see normally rexis margin can be stretched by 60% of its periphery, of its circumference. If it is strained by trypan blue, it becomes more fragile. So it tends to, I have had cases where very small rexis have torn the rexis margin just when it's trying to go to the peripheral sides to decompress the capsule. So yes, you're right. I should have made a larger exercise. In that case, I could have decompressed much more. But I thought I had, decompressed enough. But obviously, it was not enough. So I was not sure whether it was the pressure from the vitreous which was pushing the lens forward, some of the suprachoroidal hemorrhage happened or not, or whether my decompression was an incomplete process. But all is well that ends well. I mean, you may have complications, but you need to know. Don't lose your cool. Don't do anything knee jerk. So think and do it.
Thank you very much, Arup.